And the way that they normally set it up is they do a 2-day course, and then the people who've done the course to start with then get a 1-day leadership course, and then they run a 2-day course for more people. So it's trying to create a bank of teachers in the area that can then continue running the course. So this study was using the GASOC Oxford Orthopaedic Link. So this is a partnership that's been around since 2012. And it delivers the primary trauma care course in the 10 GASOC countries, which are listed there. They looked at, so there's 100 courses were delivered over 4 years. They sampled 20 of these courses, so 2 in each country, and they did 2 questionnaires, one immediately after the course and one at 6 months, which was done by a survey monkey. So they got 451 responses immediately after the course. It said that they selected 451 out of all of them. I'm not sure how many responses were done initially. I'm not sure how they selected those. But then at 6 months, the total they got was 321 responses on the survey monkey system. So the immediate post-course questionnaire was asking them, what do you intend to do with what you've learnt? And then 6 months later, they're asking what had actually happened, what changes had occurred, both to them and in their department. And they were asking about personal things, departmental equipment changes, staff changes. And they had both qualitative and quantitative responses. And then, so they managed to group all their responses into these areas, so changes in trauma management, changes in the department, changes in staff, equipment, mortality and morbidity, and training. And these were their sort of overall results. So, they found that the changes in trauma management, the majority of the people that responded said they were going to try and get a better systematic approach and using the ABCDE approach, which is, so we can't really see it on there, it didn't come out very well, which is what that one says. And the first bar is what they intended to do immediately, and the second bar is what they actually did. So most of them were doing quite well with this. Departmental changes, most of the departments did have some change, and they said that was mainly in patient management and teamwork skills around the department. They said that about a quarter found they had increased trauma staff after 6 months as well, and about 29% had better equipment. They found mainly airway equipment and cervical collars. They felt that was probably due to people feeling empowered to say we need this equipment and petition for it in their department. Mortality and morbidity, they didn't actually have any official data. It was just the people who were responding said they felt that there were less deaths and they felt that there was less morbidity. And then they asked people how many that they trained, how many other people they trained, and 68% of those who'd been on the course were training others at 6 months, which is great. So when they analysed this and looked with previous studies, there have been a few other studies that have looked at what happens when you teach people trauma care, but all in developed countries. And they show that you get increased knowledge, better teamwork, better empowerment, better skills. But there's not any other similar studies to this looking in the developing world to see how it affects things. But we can sort of assume that you're going to get that same increase in skills. They did say the limitations at 6 months. The responses they were getting, it was all self-reported. It wasn't, as I said, like the mortality and morbidity. There were no figures to correlate that with, and it's quite. It's the people who responded. It's quite a self-selective group because it was the people who chose to respond. So it may be the people who were more keen on teaching and more keen on implementing those ideas who are the ones that actually filled in the questionnaire. So we don't really know about the people who didn't fill in the questionnaire. And they say the cohort at the immediate group and the 6 month group probably aren't the same. So in conclusion, I said about half the participants had adopted this ABCD systematic approach at 6 months. Most of them were reporting they felt there was an improvement in trauma care within their departments. better teamwork, better systems and protocols in place within the department, so everybody knew what they were supposed to be doing with these patients. Teaching was better, people were wanting to teach, wanting to learn more, and that meant that they were getting more trained staff in the department. And there was this cascading model leading to more and more people being trained. They said the small increase in staffing numbers and equipment, like I was saying, may be due to better empowerment in the department and people feeling that they can petition for these things that they need. But it needs to change the clinical systems and to sort of get these courses in all the education areas needs more input from like healthcare organisations, the educational institutions, financial bodies, departments of health. But hopefully that is something that will progress. And as I said, the effect, we know that people feel that they're doing better, but we don't know whether it's actually having an effect on mortality and morbidity.
We could probably just stop sharing screen now, can't we? Because do we need the slides in?
Oh, there we go. Any questions, comments?
I wonder if the senior author wanted a comment.
Thank you very much. Yeah, I think you summarised it absolutely beautifully, all the warts and all. It was very, very difficult to get the 6-month follow-ups.
Yeah, and, I can imagine.
We did. We're slightly embarrassed that the two cohorts aren't identical, and that's because a lot of the people who did the initial follow-up then didn't do 6 months. And quite a few of the people who did 6 months didn't do an initial one. So, but they were quite closely concordant. And you asked why we chose the initial number. Well, we did the first 2 courses in each of 10 countries. So that came to just over 400. That's how we started off that's how we started it off.
Chris, I'm sure I'll go first. I mean, this, as I understand it, this was this didn't go through ethics. This isn't a study that's gone. You've taken through ethics. This is sort of a bit of additional. This is monitoring and evaluation of a programmatic piece of work. Is that right? I mean, did you put this through an ethics committee as a research piece, or is this monitoring and evaluation of your program?
Monitoring and evaluation, though we did have ethical commissions for the whole thing.
Yeah, which is different. So I mean, I suppose the in terms of the rigour, would you have done it differently second time round? And it's very so as a qualitative piece of work. I mean, the qualitative part, the issues that come out of the survey, that's probably not as rich as a semi-structured interview or a focus group discussion. And if you'd done it again, what would you have done differently, I suppose?
I think we'd probably have made it smaller and a more rigorous semi-structured interview. And we might well do it again, depending on what results, depending on what advice we get from this group. Because they're continuing to teach the course across the 10 countries. One thing that we are planning to do is that depending on whether the NIHR or other research bodies smile favourably as far, and that is actually to try to do the morbidity and mortality difference. So that's the bottom line as to whether these former courses actually help improve patient outcomes.
That would be very challenging to evaluate in any one,
right,
wouldn't it?
Yeah.
From your point of view, what are the key skills or attitudes that you're trying to impart in this course? I suppose that would determine how measurable the outcome is or not.
It's essentially a systematic approach, a systematic and quite didactic approach to trauma.
Yes.
It's the main thing we're trying to achieve.
Sorry.
There's not really time when you're treating trauma to sit and think, wonder which fluid we could use. So there's lots of options here, and there usually are lots of options, but we're choosing, we're following along ATLS, saying, actually there's lots of ways you could do this, we're just going to teach one that works. And so we want to have a quite didactic, systematic approach to the analysis of trauma and the treatment.
I've been thinking this through in the context of basic surgical skills, and the Journal Club gave some really helpful feedback about a year ago. We were thinking through our paper, and in our case there was a relatively tangible outcome in that we could assess with reasonable validity people's technical skills before and after a course. It would have been really nice to do that 6 months later as well, and then see what habits were people maintaining. So if we were doing it on a smaller scale, I wonder if it would be possible to run a moulage, for example, at the beginning of the course, immediately after the course, and then 6 months later, and see how the teams were coping with that.
Yes. That would
be all very time-consuming and expensive.
It would be trying to do that across 10 countries. When a lot of the people on the courses come from different hospitals. No, you're dead right. You're right.
So,
I think that would be very difficult.
I was just going to ask Prof. Larvey, did you have any testing within the course? Is there any formal testing within the course at all?
Do we have any what?
Any formal testing within the course, like any pre-course test or post-course test?
Yes, we did, and that's all the subject of another paper actually. The patient, the subjects, MCQ scores before the course, after the course, and again at 6 months. And then we also measured their confidence on a validated confidence scale, which measured their confidence in treating various types of trauma. We've measured that before the course, after the course, and then again at 6 months. That's the subject of another paper. This one was really the sort of qualitative stuff.
Chris, Nick Boyd here. So, just interestingly, we're doing a very, very similar concept course for anaesthesia called the SAFE course, which has both an obstetric and a paediatric course. Again, funded by THET, and we've had remarkably similar kind of structure, evaluation, MCQ skills, and we did do that follow-up skills as well. So for a project that was funded, a separate project for just Safe Peds, we did 5 countries, ran 10 courses, followed up with fellows in each of those countries doing follow-ups, multiple choice and skills and qualitative interviews with each delegate who went. So a huge kind of amount of effort in terms of the evaluation side. So it was possible to do, and we are about to, I'm just writing it up at the moment, so we're about to publish that, and it's great to see your paper, to see how it compares. But I guess the ultimate question with all of this is that it's self-evaluation. So no matter how you do all that follow-up, it's still asking the delegates themselves to tell you what changes they've made or to say what they think they've done as a result of the course. And I have this sort of concern that it's there's so much bias because the people that are doing the follow-up are from the course and they want to see that they've had a result, and they've been asked what change are you going to make at the end of the course, and then 6 months later they're following up almost to be asked, as a test question, have you done what you said you'd do? And I guess that's the real issue that I have with the evaluation of a lot of these short courses. And they how much of a bias it is, I don't know. But I just imagine it could be such a huge bias that it could be almost meaningless data.
my question was along the.
I do accept all those criticisms. I suppose it is what it is. It was a smallish paper put together with our monitoring and evaluation data.
Yeah. And we're doing exactly the same, so don't worry, we're doing exactly the same. So, and I'm about to write it up. But.
And we got it out there. To do the whole thing properly would be, do the whole thing with much more rigour would take an awful lot of time and travel. And we could do it. I think that our next big work is going to be looking at patient outcomes after there's a significant number of people in a district hospital have all gone through the course. So,
I was just going to quickly ask, were the survey monkeys anonymous, or did they put their name in?
they put a number in. Yeah.
Okay, so they didn't feel like they were being individually tested, because that would make quite a bit of difference with what you were saying, Nick.
I don't know what they felt. They may have felt that they were being individually tested, yes.
Well, I guess if it specifically said, this is anonymous, no one will know your answers, in bold at the top, it would be different to...
We did say that to them. We said, no one will be able to no one will be able to link your answers to where you are, or who you are.
Chris, I was going to ask about...
regional variation?
Good, very good, very, very good question. We didn't know. We didn't. Cool.
I missed the question.
Regional variation.
One thing that really interested me in the paper is this result of a significant increase in personnel and equipment, which it sounds like wasn't really an express aim of your course.
No. But we asked people if that had changed, and a significant number said it had, yeah.
But it wasn't a focus, or was the course a discussion of the makeup of the trauma team?
No, it didn't really. But the people who came on the course were usually people who would have a little bit of influence in how the hospital managed trauma. And I would imagine they would be able to, for example, move some of the staff to the front line to assess the trauma. And I would imagine that's how most of that increase in numbers occurred. And you could be extremely negative and say, so let's look at what other departments in the hospital suffered. Because nurses were brought to the front of the house to deal with trauma. And we just weren't detailed enough at all to look at all of that.
So following on from that, Chris, in terms of proportion, nurses, surgeons, medical officers, how did that lie? And was there a difference in terms of their response to the course and what was happening then at 6 months?
In this particular paper, no. In another paper that we've written on the things learned in the course and the things they found difficult in the course, yeah, there was big difference. The non-medically qualified people found assessment of airway really difficult. The non-medically qualified people found assessment of head injury difficult. And there were certain things that different cadres found difficult.
Chris, partly in reflection on that we need to move on and look at outcomes, clinical outcomes, and partly recognising that trauma is very much a team effort and very much driven by sort of protocol. What about doing a study which randomises hospital teams, and the control group doesn't attend primary trauma, but the whole of the trauma team in the hospital, the test hospital, does, and actually begin to look at the impact in terms of trauma delivery at the facility level. So take the emphasis off the individual and place the research focus and the research question much more directed at the hospital.
Well, thank you so much for that question. That's actually why I'm going to Zambia
Okay.
to look at 10 control hospitals and 10 intervention hospitals, where we plan to do just that, and do team training in trauma in the intervention hospitals. I don't really want to go into the details of that at the moment. It is proving quite difficult because nobody wants to be a control.
So, Chris, is that a separate course to the PTC?
Sorry?
Is that a separate course to PTC?
No.
So, are you planning to follow up on places that have already had PTC, or this is where they're completely fresh and they haven't had any PTC involvement yet?
The hospitals haven't had a hospital centred course. There's quite a few people around the country who will have been to courses here and there, but the hospitals where we'll be delivering it will be in the district.
Well, recognising that every hospital wants to eventually be a test hospital, and there must be an approach you can use to gradually bring in the hospitals into some sort of interrupted time series or something to bring everyone on board and be able to repeatedly see the impacts of running a course.
Like a step wedge.
A step wedge.
Yeah,
Step wedge probably be better.
Yeah. And that's the methodology that we will most likely use. It is still very difficult to deal with perceptions of why are you helping these hospitals but not.
Yeah. I guess if all the hospitals are on board and they're part of the process, then a randomisation of the selection just picks one hospital and pick another. If they can see it like that in an academic setting, that might overcome those problems.
Yes, and you could also say that actually the joy of the step wedge, there's lots of joys of the step wedge, but one of them is everybody's going to get the Christmas present.
Yeah.
Just we can't afford to give it to everyone at the same time. So you're getting it first, you're getting it next, you're getting it next. But everyone will get it.
I've got a question about the cascading model. So is there any worries over time that the quality of the PTC training will just get worse and worse? And is there anything that you put in place to try and improve that? Should I say the question again?
No. You didn't even need to say it.
Okay.
It is a significant worry, and there are several things that the PTC organisation is putting in line to try and keep that, to try and mitigate against that issue. And one of them is regular retraining of instructors, or re-badging of instructors, saying that when you become an instructor, you only get a limited life, and you have to do it again, a little bit like ATLS. Another thing that I don't think is actually too bad that is happening, and in particularly in the Far East, in Burma and in India, is that people have taken the course and the materials from the course and then just gone local with it, gone feral with it, and just redesigned it to the local levels of trauma they've got, changed some of the lectures. And initially I thought, oh, how terribly sad that they've changed it. But, it's a free world, and actually perhaps a little bit of local initiative, put it in parts of extra parts that are more relevant locally is reasonable. Nobody controls the world, and it's a free world. So I hope that's a long-winded answer to your question. Could the quality
I mean, it's certainly important to, in terms of sustainability, it's certainly important to assess to what extent the trainer's element of the course actually works and has impact in the sense of people being able to run the course after cool is long gone, and I think that's important. So in DRC we introduced PTC in one setting, and within 15 months we're no longer. It's a much smaller setting than what you've done, but we're no longer involved. The Congolese colleagues are running it without any input from ourselves. So I think that is perhaps also an important aspect to evaluate and to build into any research project.
Yes, well, we have found that there are some regions where a local team has gelled and is taking the whole thing forward. And there are some regions where it hasn't happened. That's quite difficult data to publish for obvious reasons. And often it's due to a very evangelical individual who just falls in love with it and drives it forwards. But I'm sure that's the same for a lot of things in healthcare.
Can I just one quick question? How do you choose which sites to go to? And on a more of a personal note, I know that they've been thinking about running the course in Somaliland on and off for the last year, and it's not quite happened. So I was just wondering how you choose sites, how it works.
We did this as a partnership link between Oxford and the College of Surgeons of East, Central and Southern Africa, which at that time had 10 countries. And our partners in those countries chose where the teaching sites would be. They tended to start off by being in the central hospital teaching hospitals in the capital city. And but we said you're not allowed to have all the courses in the capital city. And we ended up doing 5 courses per country. And at least 3 of them had to be in a peripheral region. But yeah, it wasn't up to us where the courses were, it was up to the local partners to decide where they wanted them.
Mm-hmm. Thank you.
Welcome.
So Chris, sorry, it's Nick again. I think this is really interesting, just as a general topic of short courses and how they are implemented, the impact of them. I've got to say, I'm not convinced that it has to be evaluated with patient mortality and morbidity at the end of it. And I would actually be surprised if you showed a change in mortality, not least because of the complexity of having to gather the injury severity scores, trying to make it scientifically robust, and all of the other factors that go into the confounding factors that you won't be doing as part of the PTC course. I guess the question is, how do you evaluate courses like this at all? What's the best way of doing it? And it's interesting that you've decided to do a very similar model to what we use in SAFE, but I don't know whether anyone's got any other thoughts going forward about how we should actually be doing this.
Well, I'm looking forward to going forward, but I've got some thoughts going backwards. I accept all the host of limitations with this assessment of this course, but it's very interesting. Put your hand up if you've been on a short course in your specialty at some stage, or 5 of these courses, and we all have. Have any of these been assessed? Is there any measurement of any of the courses that we usually, most of us here, will spend hundreds of pounds on? So that you put your finger on it, there's very little assessment of courses, and this is an area where I think some good work should be done in developing course assessment tools.
I think the point that Nick makes about outcome and whether that will really give us a handle on this, I think I would support. We run a neonatal surgery course, which is run here at the college for £1,000 or so. We take the same course out to different African countries. For nothing, $50 I think maximum is what is being charged by local people. Very, very frequently we get messages coming back saying that this is transformational for a pediatric surgeon to be shown all of the steps for esophageal atresia repair or what have you. And I've often thought we actually ought to try and evaluate that in the way I would imagine that it could be done. Would be using, semi-structured interviews, because again, anecdotally, it seems very clear that these senior trainees or junior consultants go back to their departments and start to get stuck into things that, before that they just felt really uncomfortable about. And I think that the way to evaluate that would be the semi-structured.
I think so. I mean, if we had a group of social scientists around this table, I mean, they would be really plugging that. Not only because that's what they live and breathe, but I think because we're all much more biased towards quantitative data, and it's going to be very hard, I think, to get good clinical quantitative data. I think that should be the focus. I'd agree.
I think that was the reason we wanted so much to discuss Chris's paper in this format, was because it's a great example of someone actually trying to do that evaluation. But I think everyone agrees we want to be able to see that what we're doing is actually creating a change. And we just thought it would be fascinating to hear everyone else's thoughts.
I think it's quite interesting as well. Just as I said, finding qualitative papers about this is quite unusual. And even in this context of the framework analysis, we're basing it on validated frameworks that already exist, and so some of what we're talking about is we're not always very sure in reality what the impact of these courses are and what people's experiences are of running them, sometimes slightly unexpected things like the impact on equipment availability. So I think it would be really fascinating. As you mentioned, Chris, one thing you might do differently was to get information from fewer people but a greater depth of conviction of that. And so obviously challenging to get people to speak freely, as you say at the end of the course, when there's an expectation of how they might report their experiences, or the expectations, as Nick mentioned, of 6 months down the line, have you done what you said you were going to do? Maybe the answer is hundreds of responses, but some focused responses that are truly giving us a closer picture of the impact of running courses in these sort of scenarios. But
I think you do it by it's not a group of surgeons or clinicians coming and doing the follow-up. It's a group of anthropologists, who are good at doing this, and there's a firewall between the qualitative researchers and the team that have delivered it. I think that's how you do that.
I think I was just going to ask also whether there's the scope to have better metrics in order to validate the course. So we talked about mortality and morbidity is something which is linked to a wider socioeconomic picture. But what about if you're teaching specific techniques on the course, whether, say, for example, the time taken to complete a particular procedure, or how many mistakes are made within that procedure while they're doing it, whether those kind of metrics can add weight to whether the course is working in both in real time and or in a simulated environment, and whether you could use those kind of metrics to see if that's improving the quality of care or their technical skills. I don't know if that's something which could be potentially done in a further study.
I think it could. And as I said earlier, working out those, designing those tools generically would be very useful to courses. I'll just end up by saying that my favourite part of this paper was figure 2, because I'm a very simple figure code. And I often think about this when we run courses. Asking people, was the course of any benefit to you back at home? It's beautiful. We didn't fix this, but it's this falls into 4. 25% of people said yes, really useful. 25% yes, quite useful. 25% said yeah, a little bit, and another 25% said no use whatsoever. And it's worth remembering that, really.
Is there a link to Myers-Briggs personalities? Or?
I was just wondering, I mean, I entirely agree about the qualitative studies. I just throw something in there. Just thinking about a comparison with use of the checklist, because obviously there's been extensive studies looking at implementation of the checklist. You could think of CTC like the surgical safety checklist, like a checklist of A, B, C, D, E trauma management, and they have looked at morbidity and mortality, and some of them have managed to show a significant improvement. So just to think about those studies that have been done in a similar area. You train someone to use a checklist, you train someone to follow a protocol for trauma management, maybe you can show morbidity and mortality outcome change.
I think you could, but I think that you would spend a huge amount of effort and energy in trying to do that. And I think that in terms of value, time and energy and money, I would say I would go along with it. Personally, I would follow a qualitative interview process and try to do it in a sort of robust way as you possibly can. And I think the risk often it's not just the way that some of the evaluation of the thematic analysis and so on. I mean, that is a skill in itself to actually do that really well and robustly, but it's the way you ask the question, it's the way that you design the whole way that a questionnaire is done and so on is hugely influential on the results you're going to get. And I mean, one of our questions that I'm going to share to the group because it's a relative confidence, but one of them was, did this course help you save a life? And 98% of delegates said that this course helped them save a life. Now, I just think I will probably write it up, and it'll probably be there in the paper in a couple of months whenever it's published. But I just don't know if that has any value at all, because I just think if I got asked that question 6 months after going on a course by the people who did the course, I would just be thinking, yes. I'll put yes. I mean, why would you say anything else?
But this is why I think having a qualitative approach towards the outcome of the course or the success of the course is difficult to do.
It's
and
very
I think
difficult to
you
do.
have to find those metrics which are specific to the skills that you learn in that course. Just like you're saying, with the checklist, it's a specific intervention which you used, and you're measuring your outcomes against that. With a course, you've got so many different interventions that you're introducing within your course material. You're not going to be able to, unless you're measuring those specific metrics which you're training up on, you're never going to be able to say that the outcome of the mortality and morbidity statistics are because of the course itself or because of any particular aspects of that course. It's basically effectively validation science. You can't validate the course if you don't have metrics which are validating against.
I disagree.
I think you can. If this is planning the randomised control trial, it sounds like that's something that could definitely work.
Yeah. I mean, but then you'd have to have metrics within that randomised control trial which you're going to compare against, right? I don't know.
What, pre and post?
Pre and post. Yeah, exactly.
Pre-mortality and post-mortality. I think the reality of getting that data is really hard. But I'd be really impressed if you managed to find a way of doing that, Chris. If you could.
Yeah, we'll let you know. We will be doing it as part of a massive study in these hospitals. So, of which PTC is only a small part of the step one.
Okay.
So we might let you know in 3 years. Good.
Right.
I've got to go. Sarah, could you possibly...
Yeah, sure, I'm primed. Shall I hang up on you and then accept Lyndon?
No, you accept Lyndon.
Yeah, for some reason it's ringing on my phone and not on the Skype on the computer, which is really annoying.
Really?
So I'm just going to turn the internet off on
Really
my
unfair.
phone, and then if you could phone back. So just give me 1 second to turn this
So once you start, still got to stop.
off, and then maybe when you ring it will come on the computer.
Don't open more.
Right.
I know, I thought about opening in the morning.
Yes. Yes.
I'm so full of junk after Halloween today, so we need to
Right? Yeah.
eat non-stop sweet.
Do you mind sending it? Is that possible?
I don't know.
Because I couldn't get it. It's like Kingston, UCR, and my business handle. It'd be very useful.
Is it ringing?
Should do.
Yeah, it
I
should be.
think so.
I don't know why it's not coming from the computer. Shall I add you and try to ring you then instead? Yeah, sorry. I'm going to accept you, Lyndon, and then ring you if that's okay, because it might work better this way.
In one of the rooms.
Right.
So I'm a very small community, always a little biased.
Yeah.
Oliver, are you better at Skype than me? Could you add Lyndon into the other call?
I'll go into that call
This one?
and just press that.
Oh, in fact,
Sorry, I'm
And then
showing
I wrote
my
it down.
age, but not being able to
they're
do
big
this.
public surgical adults, but also they had a
Right, it should come through now, Lyndon.
Yeah, it's coming. Thanks.
No worries.
It was very good. I was done with physical examination.
Here we go.
In community settings.
Is this
Great.
so
By
Thank you very much.
That's
This
so sad.
might be
Lovely
Ben.
to see you.
Thank you
Where?
for it. I hope you don't mind us choosing your paper.
No, Ben Long.
Yeah, but in Nepal or Uganda. But it sounds like this has been published, so it's a new one. Oh, if you could send us it, that'd be great. I'll send you this now. Nick, what's your email again?
Right.
Oh, that's right. Dr. Nick Boyd at Gmail.
Oh, Shirley. Yeah. Oh, so what do you want to do? Present?
If everyone's happy to go on to the next paper.
Yeah. Because if you're presenting, we're not going to see them on the screen.
Okay.
Because we're going to have to put that full screen, right?
Yeah, I don't mind. Oh. I'll just check if Rebecca wants to come back up.
This is question.
Yeah, because it's done, it did exactly what we were talking about 2 weeks ago. It's on the going out to communities, doing physical examinations, and they're looking at specific conditions. But, with examinations, just in so this would be, I mean, it's just quite interesting because they did in the presence of 10 individuals.
And so that might be an interesting thing for us to look at. That's why I said we should maybe in one of these meetings, perhaps we look at this paper and think about what should we do and what should be done.
Is everyone alright if we
Yeah.
go on to the
Sorry,
next
sorry,
one? I'm afraid I didn't organise for the lead author of this trial to attend. I apologise
How
about
rude.
that. So this is this next paper. It's the woman trial. I don't know if any of you guys have heard about it. It's looking at antifibrinolytic therapy. It came out quite recently, but it's been talked about in anaesthetic circles anyway. I think in this country a lot because it's talking about the use of tranexamic acid in postpartum hemorrhage. But really, when we go through this, you'll see it really is quite an LMIC targeted paper, and we'll explain why what we go through. So, as I said, it's called the Women Trial, the World Maternal Antifibrinolytic Trial, which is how we managed to squeeze women out of that. and it's looking at the effect of tranexamic acid on mortality from PPH and on hysterectomy. It also had a look at some of the other morbidities that are associated with PPH. The reason why it's important is that PPH is the leading cause of maternal death worldwide, around 100,000 deaths a year, 99% of which occur in LMICs. Antifibrinolytics, and I think you guys will all be aware from the CRASH trials, has shown a significant benefit in surgery in other patient groups. As a very brief recap, so fibrinolysis, you have your physiological insults such as trauma or birth, which is very traumatic, releasing tissue plasminogen activator, converting your plasminogen to plasmin, and that gets involved in the breakdown of the fibrin plug. So fibrinolysis, as this says, is activated during childbirth, and the plasma concentration doubles within the first hour of giving birth. Tranexamic acid has been around since the 50s, originally discovered in Japan, just in case of pub quiz questions on tranexamic acid. It reduces the enzymatic breakdown of fibrin by plasmin, and the systematic review shows it does significantly reduce blood loss in surgery. That's the CRASH trials we were talking about before. So the CRASH True trial, they gave tranexamic acid to trauma patients in the 3-hour window of injury, and it reduced the death by around a third. If it was given after the 3 hours, there was no benefit to the patient. The important thing from the CRASH trials, because it was debated a lot about tranexamic acid in the past, was the fact that there was no increase in the vaso-occlusive events. The concern was that if you stopped the control mechanism of the fibrin cascade, you would end up actually getting clots unregulated and blocking off your blood vessels, so you would get an increased risk of stroke and other thrombotic events. That's why people were a bit hesitant about tranexamic acid, which was one of the important things that came out of CRASH, that it didn't show an increase in these vaso-occlusive events. So since 2012, the WHO extrapolated that evidence and said, use tranexamic acid in PPH if uterotonics have failed to control a bleed. But there was no actual evidence about the use of tranexamic acid in postpartum hemorrhage. It works in surgery, it must work in other things. So the women trial, it was an international double-blind randomized control trial. It looked at women aged over 16, and people were included if it was inclusion by uncertainty principle. So if the clinician diagnosed a PPH, so above 500 mils from vaginal birth and above a litre from caesarean, and definitely thought the patient would benefit from tranexamic acid, they were given it. They were not entered in the trial. If the clinician diagnosed PPH and thought the woman would definitely not benefit from tranexamic acid, they were excluded and not given it. So the target group was women with a clinically diagnosed PPH who the clinician was uncertain whether they would benefit from tranexamic acid or not. So it was an uncertainty principle for inclusion. Where the clinician was uncertain about whether or not it would be of benefit, they included the patient in the trial. So they were given all of the usual care, then they were put down the two arms, tranexamic acid or placebo. The evidence came from 193 hospitals across 21 countries. And like I say, it was diagnosis of primary PPH, more than 500 mils for vaginal birth, more than a litre for caesarean, or any blood loss significant enough to cause hemodynamic compromise. So the contributing countries, as you can see from the numbers, it's really an LMIC-based trial. The two top ones, Nigeria and Pakistan, and then the third one, Uganda, these are by far the majority of patients, over half from these countries. And then you can see a lot of the other cases are LMICs, which is why we thought this paper is really applicable. The data from it is applicable to an LMIC setting.
But you could argue that the UK is almost might
dilute the findings a little bit. That's one of the limitations of the trial. Although it was only, I think it was only 500.
Yes,
we didn't recruit very well in the UK, but there is a potential. Although the overall trial actually got 20,000 people, so hopefully that effect wouldn't be so much. But yeah, that's something we'll come on to. So the consent was contained if capacity allowed, which is a good phrase. I'm not quite sure exactly what that meant, but that was based on clinicians' independent feeling. If the woman was able to give capacity at the time the consent was taken, if the woman
was thought to have capacity at the time consent was taken. If not, it was taken from them immediately that they were felt to have capacity. So the patients were randomly allocated to get Tranexamic or placebo. They had boxes which had 8 packets in them, and each one had 2 vials. They were either going to be Tranexamic or placebo. And a random number was generated. You went to that box and you simply took the next consecutive packet in that box. It was done by a separate company that weren't involved in the trial. It was outsourced, so it was definitely randomised. And then there was an emergency unblinding service, so if the woman continued to bleed despite using the protocol and you weren't sure whether it was placebo or tranexamic acid, there was a 24-hour phone line. You could phone, find out what they'd been given, and then you could decide whether or not to actually override it if it was placebo and give tranexamic. I don't know how many people actually used that phone number, but it was available. So the intervention itself was 1 gram of tranexamic acid, which came in a 10 ml vial. That was given a rate of 1 ml per minute, so over 10 minutes. If the bleeding continued after 30 minutes, another vial could be given. Or if the bleeding stopped and then restarted within 24 hours, they could give the second vial.
And was that second vial the same as the first one?
Yes. Yeah. So you got a pack. The packs were numbered 1 to 8 in a box, and each pack contained 2 vials that had a number on them. And it was always the same. So it was a pair of tranexamic acid or a pair of placebo. So they collected the baseline information, the intention to treat analysis, the outcome data was collected either at death, leaving hospital, or 6 weeks if they were still in hospital at that stage. So the primary outcome they were really looking at was death or hysterectomy. They looked at all causes for death, so they didn't just collect whether the patient died, they collected the cause of death, and then whether or not the patient had to have a hysterectomy as a result of their bleeding. The secondary outcomes they looked at, this trial was started before the crash stuff came out, so they were also looking at thromboembolic events. They looked at the surgical interventions, the complications, untoward medical events, quality of life of the patient afterwards, and then the thromboembolic events in breastfed babies, because that was another concern people had, was that if the mother was taking tranexamic acid, would it cause a thrombotic effect in the baby? It was done between 2010 and 2016. The baseline characteristics in each group were very similar. There was a very low dropout rate, I don't know if you can see, from the 20,060 I think it was that were included. Only 4 withdrew consent in the treatment arm, and 3 withdrew consent in the placebo arm. And then there was 11 lost to follow-up and 21 lost to follow-up. So actually the numbers at the end were quite impressive. And the results. There were 483 maternal deaths out of the 20,000 cohort. 72% of the deaths were due to hemorrhage. Of those deaths, the majority of them were in a 24-hour window, not in the first hour. Looking at whether or not tranexamic acid reduces the risk of death, overall, it didn't affect all causes of death. What it was found to be statistically significant for was reducing death due specifically to bleeding. It doesn't come as a surprise because tranexamic acid only works on that pathway.
The eclampsia was closed. Not significant.
That would be awesome, wouldn't it? Right. And again, echoing the crash trial, if tranexamic acid was given beyond the 3 hours from the initial start of bleeding, there wasn't found to be any benefit. So it was in that 3-hour window that the giving of tranexamic acid was a benefit. The hysterectomy risk in ladies who were bleeding from having a PPH, it didn't significantly reduce the risk of the patient going on to have a hysterectomy. However, when they looked back at practice, and they actually did this part of the way through the trial, they discovered that the decision to perform a hysterectomy in these settings was made at the same time, most of the time, as the decision to use tranexamic acid to enroll them in the trial. So instead of the escalation of decision making going, we'll try tranexamic acid, see what happens, then move on to hysterectomy. The surgeon would say, we're going to do a hysterectomy, let's try the tranexamic acid at the same time, because obviously of the time critical nature of the PPH. For that reason, to try to make up for that concurrent decision making and try to differentiate whether it made a difference, they had initially been aiming for a trial number of 15,000, and they increased that to 20,000. But no difference was found in the end, and whether or not, if it was a very strict escalation of therapy, try tranexamic acid first, if that fails, make the decision about hysterectomy, whether we would have seen a difference. It's uncertain whether we can actually tell that from this study. So yeah, there was no difference in whether they used the other procedures, so if you went on to get brace sutures or anything like that, tranexamic acid, there wasn't any difference there. There was, however, a significant reduction in the number of women who had to go on to have a laparotomy to treat their bleeding. So, one of the things that surprised me was there was no difference in the transfusion requirement, which some other studies looking at tranexamic acid had found that actually it can reduce need for transfusion. There was when I was looking this up, an article, a publication from Cardiff came along, I don't have the details with me, but from a couple of years ago, where they did cost-benefit analysis of using tranexamic acid versus not using it, and the reduction of its requirements for blood products. And they actually found an €11,000 drop in their costs from a year's worth of surgery, I think it was, because of the reduction in the need to use blood products versus using tranexamic acid. But, like I said, I didn't bring that one along, so there was no difference at all in the incidence of thromboembolic events, again echoing what the crash trials showed. So by using tranexamic acid, the old fear of we're going to cause a thromboembolic event, they were not borne out. There was no difference in the risk of organ failure sepsis, and the babies didn't suffer from any thromboembolic events either. If you went on to survive from postpartum hemorrhage, you didn't have a worse quality of life if they'd used tranexamic acid. So the strengths of the trial, there was good blinding, there was an emergency opt-out available for people, so patients hopefully weren't suffering from inclusion in the trial, and there was very little loss to follow-up. However, the issues with finding out whether or not there was a difference because surrounding hysterectomies, that was an issue. Other treatments given concurrently with the study because of the nature could dilute the treatment effect. And also, as we were chatting about Dr. Lilla before, the information from the UK being in there and the vast majority of the rest of the countries being LMIC, does that affect it? Looking on the relative risk reduction of 19%, I mean, that's significant in your numbers needed to treat, which I went on to calculate, your absolute risk reduction, your number needed to treat. The relative risk reduction, 19% in the UK, your number needed to treat is not going to be 250. It's going to be thousands and thousands. But in an LMIC country where the death rate is so high, it actually calculates on using this data, your number needs to treat would be 250, which is, given the cost of a tranexamic acid vial, which I found out from one of the ODPs is something like 70p, I think your cost to save one life by using tranexamic acid in this way from this study is £175, which is a fairly cheap intervention for that level of success. So, the benefits of using tranexamic acid are borne out if you use it within the 3 hours. It does reduce the risk of death, and it does reduce the risk of going on to have a laparotomy to treat the bleeding. Many deaths due to PPH do occur in rural settings, so IV tranexamic acid, is that going to be a benefit? Should we actually be going on to look at oral tranexamic acid or other modalities that can be given that could be used in a rural setting? That's actually one of the things highlighted in the paper itself. One of the other points to discuss is you're introducing a new IV drug, which, and this was brought up when I was at the OAA meeting, somebody pointed out that the IV vials that tranexamic acid come in looks quite similar to some of the vials of stuff that was there in epidural. And from case reports, there's not been a study on it, but from case reports, there's almost 100% fatality if you put tranexamic acid down an epidural. So you're potentially introducing an IV drug into places where it could have a problem, although a lot of these countries won't be doing epidurals anyway. But it is an important paper in highlighting maternal mortality in LMICs. And as we said before, if the cost per vial, and that's from a couple of years ago, I think I got 70p from one of the OPPs, but your number needs to treat cost, £175 to reduce to prevent a maternal mortality. It's pretty good going. So, points for discussion about the paper.
Very nicely presented.
No, thank you. So yeah,
Can I just ask a noddy question? I'm sure everyone else will know. I don't understand if there was a reduction in risk of laparotomy to control bleeding, why wasn't there a reduction in hysterectomy? Why else would you do a laparotomy in postpartum hemorrhage?
I think I'm not a surgeon. Maybe our OBS team can answer that actually. So has come in. She's obstetrics. Sorry to throw that out to you. But
so if it's from a normal delivery, the brace suture, for example, if they weren't stopping to bleed from normal interventions, you don't do a laparotomy by brace suture.
Can we ask you to speak up, sorry?
Yeah, sorry.
Should we put it back on the video?
So what does that involve? You do a laparotomy?
Yeah. And do a brace suture or try other interventions with various stitches.
Okay. So there's other reasons to do a laparotomy.
There are other reasons. Okay. And also I think it said pre-laparotomy, so if they were still bleeding after a cesarean section, you'd then go back in and either try and stop the bleeding or do hysterectomy.
Yep.
Yeah, I don't think they differentiated between doing a laparotomy on the table at the time or going back in. I'd have to look back at it.
Whether it was that cesarean section or normal delivery and then laparotomy.
And they tie up the uterine artery.
Yeah, you could do cardiac ligations.
And just as a reminder, what's the brace suture?
So it's a suture that goes around the whole uterus that basically just clamps it down. It looks like braces, which is why it's called a brace suture. So it goes around the whole uterus, both sides, and it's tied together, so it squishes it down.
One of the OBS guys once told me it's, when you see a ham that's all trussed up with string, that's what it looks like. That's what I got told. You can correct me if that's wrong.
Adam, our obstetrician here in Glasgow.
Ah, lovely.
Yeah, hello. Yeah, I agree that's what it looks like.
So, I'm glad I wasn't lied to then. So yeah, one of the reasons one of the reasons we wanted to chat about this was because it's as you know, this is a multidisciplinary group, and although it's the anaesthetist who's often giving the tranexamic acid, it is a paper that's really applicable to OBS and hopefully general surgery as well. Hopefully not PPHs, but the use of tranexamic acid.
Can I just ask Sarah probably and our Glaswegian obstetrician, is it normal that the decision to give tranexamic acid would be at the point of saying, oh, well, we'll just take out the uterus anyway? Or would we give it before?
You'd give it before. So you try your uterotonics to help the uterus contract, and then you'd give it after that if they weren't working. In fact, here we'd probably give it sooner, we just kind of bring it in.
Were uterotonics available in all of the settings that this trial was conducted in?
And which ones?
Yeah, so uterotonics were used as part of the standard treatment. I think it was only rolled out at centres that had uterotonics, but I don't know which ones it was that were available.
The question that I had was along similar lines to the question that Stuart has asked, but slightly different. In what proportion of the units were uterine balloons available?
That I cannot answer. I didn't see uterine balloons mentioned in the paper when I read it. I mean, Ray had specifically asked about that, but it wasn't mentioned when I read the article. I don't know if that's in the original data. I also don't know which ones used the old catheter condom technique. It didn't talk about that, unfortunately, but that would have been a very interesting thing to look at. Is there a paper? OBS guys might be able to answer. Is there a paper looking at those?
Balloons.
Yeah, about use of those in an LMIC.
Not too sure, but I can have a look in that.
you guys think?
And I don't know the answer to that either, but I'd also be very interested in knowing the answer to it. I remember doing literature research a couple of months ago, just looking in general for a set of papers that had relevance to the LMIC context. I must say I really didn't find a great deal. I think this paper by far and away is the best paper in the field.
I think it's amazing just for its ability to recruit, and it's actually keeping people in to the end of the study, although it was only looking at a 6-week follow-up period for discharge from hospital. So
yeah, I think it's a fabulously impressive piece of work given all of the challenges involved, and it's it's a game changer in terms of LMIC practice, but it's certainly something that's changed my practice and it's changed the practice of clinicians in the units in which I have worked over the past few years, in the sense that I guess previously we had that WHO recommendation, but this, I think the key thing this provides us with is well, first of all, evidence of safety, which I think is perhaps a key concern for a lot of us in obstetrics in Scotland or England, where we've got a lot of alternative means at our disposal to control hemorrhage, but also showing that there's a degree of efficacy which I think we all sort of thought would be there, and just needed a big study to show it. But both of those things would be very important.
Yeah, definitely.
Sorry, how does that relative risk reduction compare to transfusion other settings?
Do our surgical colleagues know? I'm afraid I can't remember the numbers from the first trial now. Lyndon, the other institutes in the review, remember? Oh, I can't.
No, I don't. Off the top of my head, I could tell you the relative risk reduction from that.
That makes me feel better. Nick? Awesome. Good. But yeah, that would be interesting to look at. I think Ollie is very quickly googling that actually.
And Sarah, did they report anything about the bases?
Yeah, they said that there was no increased risk in thromboembolic events. But what are you asking, like fetal mortality and stuff?
Well, anything.
Wait, it was a secondary outcome measure. Yeah, the secondary outcome measure about babies was specifically looking at the increased risk of thromboembolic events. They didn't, I don't think they mentioned about whether there was an increase or decrease in mortality rate in the babies. No, sorry.
It's all postpartum.
Well, I can't think of a conceivable mechanism for an increased or decreased risk of mortality in babies, apart from the baby decides to survive if its mum dies. This postpartum hemorrhage, so the baby's already out by the time the it's given. It would be
the thromboembolics via breastfeeding.
Yeah. What does everyone think about the inclusion by uncertainty? Because that, doesn't that sort of then causes this bias that's throughout the study? Because why are some doctors deciding this patient definitely needs tranexamic acid compared to this patient that's bleeding that I'm not sure this patient's bleeding definitely needs it? Because they're still doing hysterectomies in some of the ones that in the trial.
Previously there was no evidence, so there's nothing to say that this patient will definitely benefit and this patient definitely won't.
Almost that's an inherent bias. It's allowing people to just say, I'm including this patient in the study and not that one.
Yeah, I think the question it was specifically trying to answer was the way I tried to reflect on it, because it doesn't specifically state that in the study. It's the first time I'd heard the term inclusion by uncertainty principle, which is why I mentioned it, because I wondered if someone would pick it up. But the way I was trying to think of it was there are a lot of cases in theatre when I'm with a PPH where it's going so quickly that you literally throw everything at the patient. There's no question. If you've got it there in your armory, you use it. And then there's other cases where you're saying to the ops team, do you think we should use this? Do you think we shouldn't use it? And it's a decision made between the two clinicians. And before reading this, it was a decision made pretty much on personal experience rather than on evidence-based. And I guess it was selecting at that cohort, but whether that has a huge impact on the actual validity of the data.
They didn't differentiate the causes of the PPH, did they? So whether it was traumatic or atonic, for example.
There is some data in there, in the actual original trial data, looking at how many of them were from atony, how many were from surgical trauma. But the actual outcome, when they looked at the stats, they purely looked at the global causes of PPH.
Did they look at how many patients with PPH at their centres during the study period were not included in the study?
I don't have that information.
Because that would have been useful. Even if they used this technique and simply said there's an additional 20,000 women
that we didn't
that had PPH at these centres that we excluded from the study.
There's a separate article that was written before the trial was done, which is published on one of the statistical or one of the trial journals, and it's about 20 pages long and goes into detail on how they were going to run the trial. It might mention some of that in there. I think I included it in the email. So that's there, and then but in the actual outcome data, I didn't have that.
I guess my other concern is the consent. I mean, obviously, every study tries to get consent, but
well, how do you get? It's the same question of like a woman who's in severe pain. How do you get adequate consent from her at the time? If a woman's hemorrhaging on the table, how do you get consent from her to enroll in a trial? It did say that where possible, the enrolling in the paper. It says that where possible, the enrolling hospitals at the antenatal appointments would mention to women that they were running this trial and gain consent at that time. But the majority of the LMIC, well, a lot of the LMIC countries that I've been out to and mentioned there, I doubt they have the level of antenatal care meeting and input time where they're going to be able to run through the pros and cons of being involved in a trial. But where antenatal visits were available, they did try to consent women, whether they would be included or not in the end in the trial. They still tried to talk to women about that.
It's interesting that they said if they couldn't, they got consent from a relative. Because I mean, we wouldn't be allowed to do that in the UK, would we? You can't take consent from a relative. If you can't take consent, then you do what's
in the best interest
of the patient.
Yeah, proxy consent, as they stated it, was, as you say, relative, or if relative was not available, clinician. So it sounds like they went to relatives first, which obviously wouldn't happen in that's not how it would be here.
Is this a paper that's talked about amongst obstetricians in the UK? Is it relevant to UK practice, or is it have you been giving tranexamic acid for many years?
I think it's been discussed for many years, but from what I can see, it's over the last couple of years that it's really been used, and it's during the trial that everyone was talking about it a little bit more, waiting for the results.
So although this is an LMIC paper, almost exclusively, it is something that people have taken note of and is relevant.
In the MAGPIE trial, which mechanism sulfate was predominantly LMICs, but we very much use MAGPIE here.
Yeah, I mean, as we were chatting about the relative risk, the actual number needed to treat that you can calculate from this study is very much LMIC appropriate. If you use that relative risk reduction on the number of maternal deaths from PPH in the UK, your number needed to treat would not be 250. It would be thousands upon thousands. So I think a lot of people saw, certainly in my experience on the anesthesia side of things, a lot of people saw, 19% risk reduction, let's give everyone tranexamic acid, but actually it really is an LMIC-based, biased trial.
That's interesting actually, because a lot of these studies, because maternal mortality is so high in LMICs, you can probably only do these sort of studies in LMICs because the mortality is so low. In high-income countries, you'd never see a difference.
You wouldn't get there, yes. Good point.
So a couple of observations. So the methodology, the study protocol, is actually published in 2010.
Yeah, that, I think, actually, I'm afraid that is the pre-trial write-up rather than the actual outcome paper that I've sent you. I apologise, I think I realised that.
No. We've got the real paper. We've got the real paper.
It's just the
I found the real paper.
Oh, great. Oh, I'm glad. Yeah.
To publish on a big stage, publish a protocol.
Yes. But I was just thinking in terms of the conversations that we've been having about the pizza. The other thing I wanted to check is that the blood loss, the business about the inclusion was not dependent on different blood losses. So what they're saying is that the blood loss is the same, and it really is. They've got a graph, a figure here, substantially uncertain, as opposed to be reasonably certain, and not indicated, or reasonably certain that they are.
Yeah, I mean, I'm not a research person, so I don't know how common inclusion by uncertainty principle is, but it's the first time I've read it, and it was an interesting one for exactly the reasons that Naomi brought up.
But the other thing that I would say is that I was just going through the centres that were recruited from Nigeria, and I think it was very impressive the way because these are centres that you wouldn't ordinarily, I'd say the majority of them, associate with research. So to have gathered the centres together, to have kept it going, very few dropouts, it's quite
the thing that made me wonder about is that was there such a high uptake with it and follow through with it because these are centres where maternal mortality is something people are very passionate about and they know it's a huge issue and therefore they are very motivated to follow through? Or was it really amazing, intense researcher on the ground work, keeping people involved? And yeah, exactly, or a bit of both. But I think one could take as a reflection on just how important maternal mortality and how massive an issue it is that seem in these places. There's a very good website from the women trial that I went into actually when I was looking it up. I wish I'd gone into it before I'd read the paper because it's got a really nice little slideshow talking about the paper and giving it easy to use. But they've got quite an emotive video talking about, the former guy from the WHO, the Secretary General or something, talking about every woman, every child, and relating that to the women trial, saying, every maternal mortality is one maternal mortality too many, because not just the impact that it has, obviously, on the woman's life, but the impact on the economics of the country by producing these babies that are effectively motherless, and all that kind of thing. So I wondered whether it was that passion that pushed that through.
The funding is so complex. Funding from all these different groups. How have they done this?
It is an absolutely amazing organisational study, if nothing else.
I don't know who so there's two, Ian Roberts and Halima Shakur. Where are they based? Are they big names in obstetrics? There's quite a small group on the contributors. There's actually quite a small group. I know there are many collaborators, but it's quite a small team.
I think they're the same guys who did the Catch 2 study. Ian Roberts.
So they're not obstetricians.
No, they're from they're from London School of Hygiene and Tropical Medicine. Well, Ian Roberts is anyway.
Well, it did say no. It did say no. What's the word? Yeah, no conflicting thing at the end of it. Yeah. Although I did think I saw Pfizer as one of the contributors, so I was suspicious. But it does say no conflicting interests.
Yeah.
I'm very naive. I just believe.
And I mean, the big thing from this, for me, is okay. If this should be practiced, how many years will it be before this drug is regularly being used in remote hospitals, in LMICs, and the whole implementation science? Yeah. We know what we should be doing, but actually doing it is something else. And it'd be interesting if there's a follow-up study that looks at that.
One of the things we are thinking about doing on the basis of this was actually taking a straw poll of how many people here know whether tranexamic acid is on the WHO essential drug list. Without guessing, who definitely knows whether it's on the list or not?
Well, if the WHO are recommending it.
But they recommended it as a secondary use for nutriconics, so on their essential
I think
drug
it is.
list.
I don't think it is, but I think it is.
That's what I'm asking. But is it on the essential list for surgery? So we chatted about it beforehand. And it is actually on the essential drug list. But the interesting thing in itself is how many people don't know, despite the fact we've actually got good evidence. Does that make sense?
I think it's also on the centre of this of some countries like, it's surprisingly on that. I'm not
it's on that. It's on the global.
And that's
global
because of the.
Because I think of this, we tried to find out when it was added, and it was added within the last 2 years, wasn't it? So we think it was added on the basis of this trial.
But is it actually available in big tertiary hospitals?
Yeah.
I tell you that, it won't be available in Potter Hospital in Freetown.
No. So when in places I've been out to, I've always, not always, but I've taken my own stash, and it's not been available out there. But I thought we could, GASOC as a group, could do a little survey of our members, because we've got a lot of people who have been out to places, and ask, is it actually, we know it's on the WHO essential list, but is it actually in the theatres you've been out to? And then we could maybe, I know it's not strong enough, but maybe write a little letter about whether it is out there or not, and just get the awareness of the fact that it is a beneficial drug, and that it can reduce maternal mortality out there to make it.
But I think it's an important, in terms of dissemination of what is very powerful evidence, it's really important for researchers to go, not be satisfied with a fantastic Lancet publication, but to go beyond that. And that is part of the problems, I think, in global health, that actually the academic community doesn't then get involved in policy development and implementation of policy, because it's busy academic clinicians. But there needs to be often a better connection between the basic scientists or the clinical academics and those involved in policy work. And that is often missing. So it's fascinating to know if this is being picked up, and it is shaping obstetric policy within national ministries.
I mean, the funny thing is, as Sohan say, it's certainly, I think, influenced our practice in this country, where actually your number needs to treat is so high that whether or not it's going to make a difference.
Yeah, but here we've got regulators, we've got NICE, we've got these things. There often isn't those regulators, and there isn't clarity in policy and understanding by those who create policy. So that is why something like this would be really interesting actually to follow up. I'm sure there are, but interesting.
I'm not sure that I'm not convinced that a survey of GASOC members is going to be particularly persuasive. I wonder. I think it would be interesting as a project to think about how you might be able to do that. And it's quite complicated when you actually ask about availability of drugs in really low resource settings, because is it available readily for free? Is it available at local farms?
I'll be honest with you, it would be a whole research project in itself, much more seriously, but this was purely as a kind of interesting thing about stimulating discussion.
I mean, I think it is, I personally think it's a good project, it's a good thing to think about doing, but it's just quite complex dynamic when you look at availability of drugs, because often it's not simple as saying, is it on your shelf? It's about saying
whether you know how to use it, whether you do use it, whether the
service how it's available. How drug available is
how's that taste?
I mean, we're designing a protocol for a health system checking intervention to improve surgical, the volume of surgery and the quality of surgery that's going on in Sierra Leone and Ethiopia. And actually, that health service checking intervention is going to be a bundle of things, from community awareness to interventions at the hospital, and actually, you could add something like this into the intervention. There's probably, it needs to be a focus on key drugs and are they available and are they.
Well, for general surgery, you've got the crash
and
data.
And here is actually pre-hospital, isn't it? Pre-big hospital. You want to be giving tranexamic acid early in a PPH in the community, I would have thought.
Well, the benefit is in the pre-3 hour. The question is whether or not they're going to have the availability of the IV drugs, which is because this is purely looking at IV tranexamic acid. So the next stage, which the study writers actually suggested, and which I'm sure will come into all of you guys, is whether the oral preparations with the bioavailability, whether they would actually be beneficial in the community, being able to administer that as well.
I mean, that's where the value, I think, really low resource settings actually is, because the PPH is going to happen in the community from a birth attendant, in a small house or small community centre or something, and it's going to take many hours to get to the hospital, and the real value is to get into
So in the main tertiary hospital for women in Freetown, there were 137 maternal deaths last year. in that one hospital. You know, is it there? Is it available? You know, it would be really interesting to sort of use it in that context.
We didn't
But
have
also,
it
I
in
mean,
the-
you could do a survey, but actually be worth having a conversation with people like Andy Shannon. You know, there is. Yeah. So I mean, there was a very active global obstetric group at GASOC Journal, Professor Andy Shannon, who does all the cradle studies for preeclampsia. So it'd be interesting to ask a group like that. You know, what is their view of how this then translates into practice and how it has greatest effect? And they'll have a whole lot. They'll probably talk for an hour on it. You know.
I mean, I should know the literature, but existing child in trauma. Because what about
Yeah, that's the crash trial.
That is it. It's not. So I thought you said it's just in surgery. I don't mean like
No,
trauma as a roadside type.
So it's pre-hospital trauma.
Yeah.
They did do pre-hospital trauma now.
So that's what happens now. If you get knocked off your bike down the road, they'll give you some Tranexamic.
And I mean, that again has kind of made its way into theatres up and down the country.
It's just become
And even elective orthopedics, it's used regularly.
Everyday drug in a lot of places now. Thanks very much, everyone.
A great discussion, and it's great to have obstetricians, anaesthetists, and surgeons together.
Yeah, well, hopefully what we'd like to do, I mean, I know the surgical guys have been doing amazing work on this for the past year, but hopefully what we're going to be doing now is, I mean, Rebecca and I tried to choose papers that wouldn't exclude everyone else that would be of interest to anaesthetists and hopefully surgeons and all these guys. So next time around it will be our obs colleagues who will lead, and then it will be surgeons and we'll sort of rolling rotation, and hopefully get a wee bit of multidisciplinary chat going on as well. Thanks very much for coming.
Are you based here?
Yeah, not Oh, yeah, thanks. London, lovely to see you again.
Thanks, Oxford. Thanks, Glasgow.
See you guys later.
Bye, Kat. Bye, Kat.
I'll see you on the call tomorrow. 2 o'clock.
Yeah. Probably not C. I think we'll just hear each other.
Yeah.
Yep.
Thank you.
Thank you.
Thank you.
Yeah, thank you guys for setting it all up. That was a nice surprise. It's normally me coming in trying to fiddle on the technology.
I was worried about it, to be honest with you, because I had no idea what